Welcome to this explainer. Today, we're putting on our detective hats to decode the intricate anatomy and pathology of cerebrovascular diseases. Stroke is a leading cause of disability worldwide, and understanding it, well, it requires way more than just memorizing textbook facts. It requires a really systematic, almost investigative approach. So, we're going to break down the exact mechanisms of brain ischemia, map out the vascular territories, and figure out how to read the clinical clues our patients actually present with. Let's dive right in. Here is our roadmap for today. We'll start with the neurologic method, then look at the pathophysiology of ischemia, mapping anterior circulation, mapping posterior circulation, brainstem stroke syndromes, and we'll wrap up with diagnostic neuroimaging.
All right, let's kick things off with Section 1, the neurologic method.
The core method of any good neurologic detective is working backward from the clinical deficits. You absolutely must ask first, where is the damage located? Like, does the patient have right-sided weakness with aphasia? Because that points to the left hemisphere. Or do they have weakness without aphasia, pointing to a deeper structure? Only after you've confidently nailed down the where should you move on to ask what caused it. It's a strict two-step method, but honestly, it prevents massive diagnostic errors and makes sure our use of technology is actually targeted. Now, you might be wondering, what's the actual cutoff between a TIA and a stroke? It comes down to whether blood flow is restored before permanent damage happens. If all those neurologic signs resolve within 24 hours and imaging shows zero evidence of infarction, that's a TIA. But if those symptoms drag on past that 24-hour mark, or if we literally see dead brain tissue on our scans, well, then the diagnosis is a full-blown stroke.
Moving on to Section 2, pathophysiology of ischemia.
We really need to zoom in to the cellular level here. This step-by-step ischemic cascade is basically a deadly chemical chain reaction. Because our neurons don't store glycogen, energy failure happens in just seconds. No oxygen means no ATP. Without ATP, the cell's ion pumps just completely fail, leading to rapid cellular depolarization, and that dumps a massive amount of glutamate into the extracellular space. This sustained glutamate release acts like a floodgate, causing a huge influx of calcium into the neurons, which produces reactive oxygen species that literally destroy the cell within minutes. It's incredibly fast and it's catastrophic. Which brings us to Section 3, mapping anterior circulation. Take a look at this. Notice the middle cerebral artery, or MCA, right there, along with its tiny, deep penetrating branches. Those are the lenticulostriate arteries. In this coronal view, you can see how these really delicate little vessels branch off at a sharp angle to supply absolutely vital deep structures, like the basal ganglia and the posterior limb of the internal capsule. So an occlusion here might be physically tiny, but because it hits such highly trafficked neural highways, it causes profound, devastating clinical deficits. Now, what's genuinely fascinating about this lateral view is how the MCA branches divide right in the Sylvian fissure to supply major, distinct regions of the cerebral cortex. You've got the superior division projecting up and the inferior division sweeping down. Together, they cover the vast majority of the lateral surface of the hemisphere. That includes our primary motor and sensory areas, plus our critical language centers. If we flip over to the medial view, we can perfectly trace the anterior cerebral artery, the ACA, covering the frontal pole and sweeping right along that supromedial border. You can also spot the posterior cerebral artery, handling the lower temporal and occipital poles. Why does this matter? Well, if your patient presents with weakness, primarily in their leg rather than their arm or face, this medial map tells us to immediately suspect an ACA issue. That's exactly where the leg motor cortex sits. So the crucial point here is that you can localize the exact division of the stroke just by observing your patient. A blockage in the superior division hits the frontal lobe, right? So that causes contralateral weakness and expressive Broca's aphasia. They know what they want to say, but can't get the words out. On the flip side, an inferior division clot spares the motor cortex completely, but damages the temporal and parietal lobes. That leads to severe sensory loss and fluent, but totally nonsensical Wernicke's aphasia. It's like a giant puzzle coming together.
Let's travel to the back of the brain now for Section 4, mapping posterior circulation.
The entire brainstem and cerebellum rely heavily on this single basilar artery, right in the center. You can see it's formed by the two vertebral arteries joining together at the pontomedullary junction. And from this central trunk, you have countless tiny branches diving directly into the brainstem. This is a massive vulnerability. A single clot in that basilar artery can devastate the brain's most fundamental life support centers.
This takes us directly into Section 5, brainstem stroke syndromes.
Because the brainstem packs so many critical nerves into such a tiny space, ischemic damage produces very specific syndromes. This table does a great job of chunking the geography for us. For example, profound vertigo? That usually means the vestibular nucleus in the medulla or pons is hit. Unilateral gaze paralysis? The lesion is almost certainly in the pons. And if their eye is blown out and pointing down, the third cranial nerve in the midbrain has taken the hit.
This cross-section brilliantly illustrates that precise structural anatomy we're talking about. In this axial view of the midbrain, look at the third nerve nuclei right near the center. You can see their nerve fibers projecting outward, right past the red nucleus and the massive crus cerebri, which, by the way, houses those all-important descending motor tracts.
And that specific layout explains something super fascinating: crossed deficits. Take Weber syndrome, for example. Damage to the third nerve fibers makes the eye on the same side of the lesion look down and out. But because the stroke also hits the adjacent cerebral peduncle, where motor fibers haven't yet crossed over to the other side of the body, the patient has paralysis on the opposite side of their body. No way, right? One small stroke, two dramatically different localized signs.
Finally, let's confirm our detective work in Section 6, Diagnostic Neuroimaging.
Here is a great head-to-head comparison of our two main imaging tools. On one hand, we've got the super rapid non-contrast CT, which is our immediate go-to in any emergency room. On the other hand, we have the highly sensitive MRI, which uses advanced sequences to map out the exact vascular architecture and pinpoint those areas of acute ischemia with incredible detail. So why do we use both? Well, the clinical takeaway is that we rely on the CT instantly to make sure there is no dangerous bleeding in the brain. That dictates whether we can safely give clot-busting drugs. But the MRI, it's vastly superior at spotting the actual infarctions. A diffusion-weighted MRI can detect cellular swelling from ischemia within minutes, and it's absolutely crucial for seeing small strokes in the brainstem, where a CT scan often just completely misses them. Now, this is where it gets really cool. This perfusion scan highlights the concept of the core infarction versus the surrounding mismatch area. See the pink? That's tissue that is already irreversibly dead. But the green areas, that represents brain tissue getting dangerously low blood flow, but it hasn't died yet. Calculating this difference is vital in modern care to see if a patient could still benefit from an emergency mechanical thrombectomy to just go in and pull that clot out. Honestly, everything we've talked about in this explainer, the neurologic method, the anatomical localization, the rapid imaging, it all boils down to one absolute mission: saving this ischemic penumbra. This is a brain tissue that is functionally silent because it's starving for blood, but it isn't dead yet. If we can restore perfusion fast enough, this tissue wakes back up and the patient regains function. I'll leave you with this thought to consider. We always say time is brain. As our neuroimaging gets faster and more precise, the real bottleneck in stroke care is often our own initial human detective work. How much more of the human brain could we salvage in those critical moments if we perfect our clinical localization skills? Thank you for exploring cerebrovascular diseases with me today. Keep asking where, keep asking what, and keep learning.